Our next panel discussion is on the topic of connected health, a smarter future for healthcare. In this session, we would touch upon the role of connected health playing in current time. To start a flow of transformative ideas, we have very eminent dignitaries, both physically and virtually present with us. I invite on stage Mr. Dsouza, who is the co-founder of HealthAssure. Welcome. I invite on stage Dr. Nageshwar Rao, who is the Group COO of OMNI Hospitals. I invite Mr. Piyush Bhan, who is the Senior Vice President of International Business at Salucro Healthcare Solutions. I invite Mr. Dilesh Dattani, who is the Head of Products of BestDoc Technology Private Limited. I invite Mr. Akhil, who is the founder and principal consultant of Trizone Healthcare Consultants. I also invite Dr. Nitiraj Gandhi, who is the Associate Director at IQVIA, India. To join us virtually, I invite Mr. Andru Tsai, who is the Assistant Manager of Sales Department at EBM Technologies. We have him virtually. Welcome. Dr. Nitiraj Gandhi would be leading this panel for us. So over to you now, sir.
Hello. I hope I'm audible. Thank you so much, Voice of Healthcare, for organizing this wonderful summit. I think some great sessions since morning. And thanks for settling us down in the post-lunch session. I think that should be a good wake-up call. The kind of panel I have is an interesting one. So let's start with connected healthcare first. When we say connected healthcare, healthcare does not begin without a patient. And everything that we do essentially has to be around the patient. So when we say connected healthcare, it refers to the continuum of care. That continuum of care involves multiple things. That involves the role of hospitals, home care providers, telemedicine solution providers, payment solutions for such large amount of transactions and varied natures to take place, as well as patient relationship management. And luckily, we have all of representatives from all of these different solution providers on the panel. So thank you, Voice of Healthcare, for that. Maybe I'll just give a minute each for each of the representatives to give a short profile of themselves, and then we'll start with the questions. Dsouza, please.
Hello, am I audible? Hi, good afternoon all. Thanks to VOH, we all are here. Myself, Dsouza, I'm the co-founder for HealthAssure. I manage the networking, partnerships, operations, and the insurance business for HealthAssure. Previous to this, I was with ICICI Bank and United Healthcare. Thank you.
Good afternoon, ladies and gentlemen. Myself, I'm Dr. Nagesh Rao, coming from Hyderabad, working in the capacity of Group Chief Operating Officer for a chain called OMNI Hospitals, which has got presence in 2 states with 6 hospitals and 1,200 plus beds. So I come with an experience of around 15 plus years, both in Indian subcontinent and in African continent. And my background is in emergency medicine, but I've been in the business of running hospitals for the last 12 years. Thank you.
Good afternoon, everyone. Can you hear me? Yeah. Myself, Dilesh Dattani. I head the products division at BestDoc Technology Services Limited. We are into healthcare, I would say OPD and IPD automation. I've been with BestDoc for the past 4 years, and prior to which I was working in Infosys, doing ERP implementations across geographies. That's it.
Hello, good afternoon. Myself, 𝐿, founder and principal consultant, Trizone Healthcare. So it's like, we are solving the greatest challenges into healthcare. Everybody requires that, the patient footfall, the reputation, and obviously the revenue. So we are into the branding and marketing, and we are providing and we are assisting our healthcare clients for branding and marketing 360-degree solutions.
Hey guys, Piyush here. I represent Salucro Healthcare Solutions. Salucro is into integrated payment systems at the hospital side, outside the hospital side, online, and different payment systems that could be available for a patient to make payments. We're easing the patient payment journey and improving the patient experience. I've been into fintech and health tech for almost 12 years, and helping improve healthcare is one of the biggest challenges, improving the processes, and that's where I'm focusing myself exclusively in healthcare. Over to you, Dr. Gandhi.
Thanks so much, Piyush. Andrew, would you like to spend a minute introducing yourself?
I'm Andru Tsai from 𝐕𝐎𝐇 Technologies from Taiwan. I have a 10-year experience in medical imaging technology domain, also called PAC system, picture archiving and communication system, specifically in system planning and deploying. Furthermore, I dedicated creating optimal image service role.
Thanks so much, Andrew. I think we lost you for the last 5 seconds, but welcome to the conference. Yeah. I'll start with Delhi now first. Delhi, there's a large consumer market gap when it comes to primary care, and especially the access to quality healthcare. If you look at the urban-rural divide, it doesn't just exist in terms of infrastructure, but it also exists in terms of access to good clinicians. So how are you doing things differently at HealthAssure?
Sure. Thanks, Doc. In the Indian context, healthcare is inadequate and complex. For individuals, first, it's about the tertiary care, which deals with hospitals, managing life and death situations. Next is the primary care market, which helps individuals to manage their lives on a day-to-day basis. Focus on the primary care adds a lot of value to health, overall health of the population in general. If an individual manages his health on a day-to-day basis, he wouldn't visit the hospital much more. One of the biggest gaps in this market is inadequacy. If you look at the country, you'll find maybe an Apollo clinics and an SRL center across the nation. You may not find a third one, who's just spread out all across the country. Second would be the quality of services currently rendered is a challenge. Third, the discounts, the pricings, they fluctuate at such a large extent that creates a lot of doubts in the mind of the consumer. And fourth would be the complexity of getting all the facilities under the same roof for consumers. They have to travel multiple places to get everything done. Having said that, at HealthAssure, what we have done is we have connected the consumer to a network of 5,500 plus partners across 1,200 plus cities. Apart from that, we've also looked at, the telemedical side of the business, where we have a good 150 doctors managing consumers remotely. Now, when it comes to connected health, in simple words, connected health is a digital model for managing healthcare and delivery. Okay, this allows consumers to connect to medical providers very quickly and conveniently than ever before. Examples would be your telemedicine business, mobile personal emergency responses, decentralized clinical trials. These would be a few examples of connected health. Obviously, connected health bridges the gap in the primary care market. Imagine a consumer who's in a remote location wanting to connect with a specialist doctor. Right now, he can do it through various platforms which are available. Similarly, people with diabetes, they can easily transmit their values to their diabetologist. So yes, connected health is the answer and the way forward for us. Thank you.
Thanks, Delhi. So moving to the clinical side now, Dr. Nageshwar, I think you've had greater experience than most of us, especially being a clinician at heart and then an administrator. When we talk about continuum of care, there is care that you deliver at the hospital, and more important is the follow-up that happens at home, how people are monitoring themselves. A lot of home care companies have also come into the picture. Now, when it comes to quality, cost, and technology, how do you manage that?
Right. I mean, I might be talking most of the times on behalf of the consumer, because when you look into the ecosystem of telemedicine, the provider, a facilitator, and a consumer, we fall somewhere in the zone of facilitator as a hospital or a practitioner. Telemedicine provider, somehow for the reason that they have failed to gain the confidence of the practitioner, saying that the patient and the doctor relationship is not going to be at stake. A lot of practitioners do think this telemedicine application or the telemedicine ecosystem is going to disrupt the relationship between the doctor and the patient. And that's exactly where I would say the providers have still need to work a lot on getting these people on board, and all these stakeholders have to be partners in this journey. There's no doubt the pandemic has proved how important is telemedicine, and the way the government has announced whatever budgets that they want to put up into this vertical. And it has proven itself, saying that I think telemedicine can bridge the gap between the supply and the demand that we have in this country. Now, not just talking about the doctors, even if you look at the hospitals think telemedicine is going to cut down the visits to the hospital by the consumer. We always measure our performance in terms of footfalls and revenues. When we say, look, you don't need to come to the hospital, we will connect with you over whatever application that we have, and we can continue with you. And then now hospitals think we are cutting down the footfalls to the hospital by giving them service remotely. And whatever, someone visits to the per patient spend, I'm sure, I think one of our colleague here who heads this OPIP application that they have, we strongly believe the footfalls will always directly relate to the revenues of the hospital. When these footfalls are being at jeopardy because of these applications or whatever technologies that we're going to do at the betterment of society and the patient, but ultimately the business model is what exactly the people are not really convinced how to go ahead with this. So this kind of dilemma on the administrator's mind and the clinician's mind. Even today, the clinicians think telemedicine is actually taking all our patients away from us. In a way, it is true. I mean, see, it is also in a way it is better. The doctor is more conscious today that he cannot afford to lose his client. He cannot continue to drive clients at his own whims and fancies, saying that you need to wait for 5 days, 7 days, 8 days to get the appointment. So he has got a lot of options. Today, the consumer has got a lot of options. India is a buyer's market. The buyer can decide what he wants. So it's the same. We are happy to see that coming into the healthcare, to be very honest, being a healthcare administrator and the clinician. But I think the platforms which are coming up now, platforms which are in use now, have to really gain the confidence of the mediator, who is the doctor, and the organizations. Ultimately, the hospital should be able to convince the consumer to go ahead with this telemedicine health for the continuity of the care, which is not really happening as expected today. So I think unless all the players, all the stakeholders in this game come together, join hands, and then of course we have our own ways of interest looking at business, and then the way if you look at your top line, your bottom line, ultimately I'm sure this telemedicine vertical is going to help you in retaining your client, number one. Just because you're not available, the client is not going to somewhere else. They are going to ensure that it's going to come back to you either in the remote way or virtual way, whatever way that you have created. I think these are And hospitals should able to understand, though there is a decrease in the footfalls, the retainment of the customer, the stickiness of the customer is going to improve with these applications. I think today we spend a lot of money on branding, marketing, advertising, whatever it is, to retain and to create the stickiness with the consumer. Now, if you look at the spend against these activities and whatever loss that you might incur because the patient have not walked, sorry, I'm using patient because I'm a doctor. So the consumer is not walking into your organization. That versus if you look at the amount that you're going to spend on those hoardings, billboards, advertisements, it's nothing. So the issue here is someone should come up with the data. Doctors they don't have time. They will never look into the data. But yes, if there is someone who can actually make them explain and then say, look, this is what it is, I'm sure they'll buy in this idea. I think the biggest gap and the challenge, Dr. Gandhi, today in India about telemedicine, though everyone is trying to talk about the same thing, but I think all the stakeholders in the game are not on the same page. These can actually be much, much better than what we all expect, and the kind of population we have, the kind of demand and supply that we have in this country, and this vertical is nowhere less to any kind of, I mean, in the healthcare vertical today, after pharmacy and hospitals, I think it's a telemedicine vertical which is going to make its list in the coming years. And I think this needs to have a lot of buying in from all the stakeholders. I think that's a big challenge. And from the consumer side, the continuity of the care, do we have enough devices to integrate with these applications? If someone complains to me on a call saying that I'm having difficulty in breathing, am I in a position to see his saturation going live? Am I in a position to see his ECG leads going live? Am I in a position to see his blood sugars, or am I able to auscultate his lungs sitting somewhere else? I'm pretty sure there are devices, no doubt about it, but I think the sensitivity and specificity of these devices are not yet proved. It's a journey, I agree with you, but I think this journey has to be expedited. And as I again said, we all need to come together in this journey. And these kind of integration of devices, endpoint care devices with the applications is also very important. Not just developing a software and then application, leaving it on to the people and say, let's go. So that's another area, where I think is a big challenge. Thirdly, the credit payers of this country, especially could it be insurance or could it be public corporates or private corporates, they have to buy in. They have to come into the picture. There's only one insurance which I know which is actually into home health care. They're ready to sponsor home health care as a primary sponsor. But we have around 30 major insurance players in this country who are into health insurance. And we have only one player who is into, with lots of terms and conditions on that again. So now we have to come out of all this. The insurance player should think about how to get the access to telemedicine in a vigorous way rather than thinking about exploitation of telemedicine by someone else. So I think these are the important areas where all of us, if can put our hands, and brains and hearts together, I'm sure this telemedicine vertical is definitely going to be one of those top 3 revenue generators for the country, and the best in case of accessibility of healthcare to the common man gets better. Thank you.
Thanks so much. Very passionate of you. Now I'm just going to do a small experiment where I'll ask a question to Piyush and Dilesh can probably answer them together. So Piyush, doctor spoke a lot about telemedicine, home care. People want to take care of certain services. I want to do a vaccination in a vaccination center, an OPD visit somewhere else, pharmacy payments in another place, and there is an online pharmacy or diagnostic, e-diagnostics is the new in term where everyone wants to say that a part of connected healthcare is always getting yourself tested, investing in primary healthcare. And that poses a challenge in terms of How do you make payments? How do you reconcile those payments? What are the different modes of payment? So I'll start with you in terms of how do providers address these challenges? And then I'm going to Dilesh in terms of managing the patient relationship across across this spectrum, this wide spectrum. Yeah, over to you.
Thanks for bringing that up, because that is one of the key areas that we, in terms of the payment solutions and the payment systems, always talk about. Before I, really pick this up, I want to touch base on something what Dr. Rao really mentioned is integration. Now, and that answers the part of the question that you're talking about. Now, why we continuously talk about integrations in this phase of the journey is because two strategic events happened: sad, bad, good, whatever you may call that. One was demonetization, and the second, the COVID waves that we encountered. And that is something that emphasized how integrations are really critical, not just in terms of payments, but in terms of everything. So he talked about devices. Now, if those devices were available in the remote places and the data could be fed in through those remote places into these applications that they're using, the servicing could have been easier. The diagnosis could have been, earlier. Now, in all these activities, the hospitals, the clinics, the centers, they need to get paid. Now, how do you pay? If I only throw out that, okay, I only accept payments at my hospital location, it doesn't really work. The person is sitting remotely. How do you bring those changes? So there has been, I would say, a transition over a period of last 5 to 6 years where hospitals, healthcare systems have started focusing on IT infrastructure, which was not the case 5, 6 years before. Because now everybody in the healthcare space is also realizing how connected systems, how digitized systems are really crucial for the next generation, or the next set of operations that they're picking up in. Now, bringing in multiple payment options, credit cards, online payments, payment links, UPI transactions, phone push notifications, the recent, you have these buy now, pay later apps. You have multiple payment options as a consumer, as a customer, as a payer. Even if in this room, if I talk about and ask you to open your phone, you will have at least 10 mobile apps through which you can make payments. You have Paytm, you have PhonePe, you have Google Pay. Now the hospital says, you know what, I can only accept PhonePe. And you're like, why? I can pay through Paytm, I have it in my wallet. I can pay through my phone tap, why are you restricting me? And that's where this shift is happening in the hospitals. And for the hospitals, the reason that they stay away from it is it's operational as well as accounting. And it also involves a lot of technology and a lot of complexity. Now, they've always been wanting to do it, but they couldn't do it. They step away from it because it's another nightmare for them. And not just for them, for the operations team, for the patient experience team, for the accounting team. Imagine you sat at your home and you did a PhonePe payment, you come to the front desk and you say, I've paid. And the front desk says, okay, you know what, wait for 5 minutes. I'll check it out with the accounts team. And that 5 minutes turns into 45 minutes and they're like, okay, we cannot trace your payment. I'm sorry, we cannot give you service. Imagine the frustration. So what Dr. Rao said in terms of connecting these pieces and what Dr. Gandhi talked about, when payments are being done at different facilities, how does a hospital know about it? How do you give them these services? So bringing these connected systems, bringing that one platform that has all the payments, all the solutions in one place, not just helps you in collecting the payments, but the accounts team in reconciling those payments against each and every bill. What payment happened? Where did it happen from? What time it happened from? How much settlement did I get? All of that gets taken care of. Though, when you listen to all of this, it sounds, it's very easy and it can be done, but this is very complex in the back end. There are so many things that need to be put together, and building these platforms has never been easy. So what Dr. Rao is talking about, what Dr. Gandhi, I totally agree. There has to be systems who talk to each other, who can communicate, who can improve this journey of payments, because India is a prepay market. Unless you pay for your services, you're not going to get the services. And once you do that, that's when you're going to go to the next step, wherein patient experience comes in. And for that, I'll hand over to Dilesh to talk about it.
Thank you, Piyush. So I'll take it up from where Piyush left it. Integrations, right? So see, post-COVID connected care is a reality. We all know that, right? And then what we did right from our inception is patient centricity. In whatever solutions we offer, patient has been the center point for us, be it pre-care, point of care or post care. So that's the main tenet which we hold on to. And what we did was we charted out the OP patient journey, right from booking the appointments to reaching the hospital, or before that, reminders, reaching hospital, and then consulting a doctor, getting to a pharmacy or a radiology lab, and then going back home and giving feedback. So all these points we examined, and we thought that patient has to be given some amount of convenience at all these touch points. And that's how we came up with different products which we have today. For example, booking, you can sit at home, go to the hospital's website, make a booking, you can see the slots and come in at that slot time itself. When you come to the hospital, you don't have to necessarily go stand in a long queue there. There are kiosks available which will help you to do check-in, registrations. In fact, registrations at some of our partner hospitals is taking less than 2 minutes. What used to take about 8 minutes is less than 2 minutes. So that's where patient centricity comes in, where we are getting involved there. Then queue management, that's another area. Having curbside check-in. That kind of a model exists in retail. We thought, why can't we do it in healthcare? So contactless check-ins. Telemedicine, of course, we all know about that. And now we are getting into IP areas, what Piyush was mentioning. Why can't a patient or his bystander from the comfort of the room make payments? Why do they have to come down and stand in a line? Why can't we provide an application, which we are already doing? It's a handheld device. The nurse can just go to the room and ask the bystander to make a payment, and they get the receipt then and there. And we integrate with the HIS systems available within the hospitals so that it's a seamless experience for the patient. Patient is benefited. And then now we are getting more into IP space where we are trying to say, we all of us have heard this multiple times, like patients or their bystanders complaining that I have made so many requests to the nursing staff, but some of them are not fulfilled. I don't know what's happening with them. I have to do follow-ups. Nursing staff says, we are burdened with so many things. We forget something sometime. So we thought, why can't we bring in something where the patients or their bystanders can directly raise requests from their rooms? And that goes to the respective departments within the hospitals. And they get the transparency of tracking the requests. If I can track my requests and see who's it assigned to, that makes my life much more easier. I don't have to follow up, right? So that's how we are trying to make patient-centric solutions and going forward in that direction. And next, we are again trying to come in with virtual help desk and see as wearable devices you mentioned. How can a nursing staff monitor the vitals from the nursing station? We're trying to explore those aspects as well now. Thanks, Dr. Nagesh.
Thanks so much, Dilesh and Piyush both. I think great insights. Now I'll go to Akhil. I think some of the most important points will be addressed by you. How to bring the patient in, and how do you connect with the patient to get more and more patients and get visibility for your hospital? How do you communicate about different kinds of services that are available at a facility? I think no one better than you to explain that.
Thanks a lot. Thanks a lot, Dr. Gandhi. So from morning, me and Dr. Gandhi were discussing about this point. So we at Trizone Healthcare strongly believe in one saying that is innovated by us only, by experience. That is like knowing is knowing and doing is doing. We have, we have odd 100 people are there here. All are geniuses, all are decision maker, all are, extraordinary people into the healthcare ecosystem. We have certain people like from government also, from international forum also. We have a voice of healthcare, a platform, very good platform, who can advocate and, help us to create the policies and everything. From morning, we were attending the various sessions, and what I noted down in a, there is a problem, there is a challenges. And obviously there is a problem, there is a challenges. So there is a, amazing solutions. We have it. Ayushman Bharat Digital Mission Yojana. We heard about it, and I think it has been launched in September 21, I believe. September or November 21 by Honorable Prime Minister. And we got this Aadhaar card. How many of you have this Aadhaar ID? Okay. So we are here for a future of digital healthcare. Right? So that's what I'm talking about. Knowing is knowing and doing is doing. We have the solutions with us only. We are the key changers, key policy makers. We are the change makers, actually, who can, make this thing possible. I was talking to this Bhamasa Swasthya Bima Yojana. I was like very closely working with the Rajasthan government in 2015, where, Rajasthan government had launched this Bhamasa Swasthya Bima Yojana in Rajasthan. It's amazing software they had created. And Ayushman Bharat software has been, a little bit driven by Indu Bhusan, and driven by that software. And that's what the, entire Ayushman Bharat software we are using. That time, after 3 years of that Bhamasa Swasthya Bima Yojana, we were talking to the government, NHM and all, that, we have lakhs of people who had been operated, who had been, treated in the various hospitals. And because it's like a seamless process, the data-driven process, the billing system to the, the entire process there was fixed MDP, minimum document protocols, payment cycle has been made through that thing. So we were like, discussing when Ayushman Bharat is supposed to launch, that where are those datas of lakhs of patients who has been treated. So we got a very interesting, answers from the DOIT, Department of Information Technology, that we have that data, but it's in the scan copy. Because the majority hospital has, forwarded or uploaded that particular data in the scan copy. Which is fine enough. Like, we have a technology, we have engineers, we have genius people who can, read that scan and get the data. So we can always get the, basic data, how many of, diabetic and hypertensive and all those things. And being into the marketing, we always work on a data-driven marketing strategy. So data is the key, We require that basic infographic or info of the patients. So I discussed, like, where are those data? So they told, like, it's very difficult because the end users, the kind of, hospital, those who are, processing the claim or doing that billing, they are not educated enough to do a scan copy. Half of the time, our Aadhaar card, it's like, Aadhaar card linked system, Yojanas. So they're linked with the Aadhaar card, but at a, ICU or say OT, the nursing staff who are doing that, the patient consent or a billing or anything. For example, say my original name is, Aadhaar card name is Akhil Chandra Dave. So in HMIS, through Aadhaar card, it will be a Akhil Chandra Dave. But if I'll go into this cath lab or a OT or any procedure, there would be a like Akhil Dave, like, here, Akhil Dave. So there are duplication of a data. There is, a kind of not a precise data. And that's what the challenge is. So I think whenever we consult the various healthcare providers and solutions providers, we always say that, in healthcare, let's do an inside out. First, we need to do a internal marketing. Internal marketing means let's educate our own people, because knowing is knowing and doing is doing. Let's do it ourselves first, internally, and then let's, do it outside. And connected healthcare, yes, we can do it. And we have amazing people, amazing technologies, and amazing government policies. I think in very near future, I think kind of a voice, VOH, is into this kind of a forum and passionately organizing this kind of a forum where, people can interact and exchange the idea. We can do that connected healthcare, provided we all first connect with each other in that passion that, we really want to deliver those kind of a care to the end users.
So much, Akhil. I'll go to Andrew. Andrew, I hope you're able to hear us.
Yeah. Good afternoon. I'm Andru from ABM Technology.
You're mute, Andrew. We can't hear you.
Yeah. Okay.
Yeah. Okay. So, Andrew, just a few insights from your experience with teleradiology and the work you've been doing in Taiwan. That would be great to hear.
Yeah. Okay. Good afternoon. I'm Andrew from ABM Technology, and we are expert in PACS and found varies in scale from mega to the micro, which means from the close facility utility to personal usage, we can handle that. Also, we fitted it into the cross-departmental or cross-discipline scenarios from radiology, sonography, endoscopy, mammography, dentist, photography, even the pathology. We also participate in the governmental platform in Taiwan. Several nationwide projects, such as IRC, Image Reading Center, a telemedicine service platform, and the EEC, Electronic Medical Records, abbreviated as EMR, exchange center between health facilities for EMR logistics. Such experience of a cloud-based practice. And go back to the issue of IRC. This telemedicine service is provided by the Ministry of Health and Welfare of Taiwan government for Island County and the rural area, which with the indigenous tribes, and start with the teleradiology. Due to the uneven distribution of the medical resource, teleradiology became the start of the telemedicine of this government project. We aimed the Island County and the remote rural tribes, send the trained technicians to the health center. Health center is similar to a clinic to perform the examination, X-ray examination for the local people. Therefore, they don't need to travel distantly only for such minor examination. And about the scale of the IRC, there are 75 health centers classified as the remote area around Taiwan. Half of them participate in this platform. They upload digital X-ray image to the IRC center in search of diagnosis. Radiologists in the medical center take these missions and report for them. Furthermore, we noticed that there are other image type exam also suitable in such kind of an environment. Thus, we put the ultrasound and the ECG as the service contacts in the IRC. Recently, we evaluating the founders' examination to improve the variety of the service category. IRC provide mobile DICOM viewer that the doctor could review the exam performed in the health center during the mobile medical service. Therefore, the patient don't need to go back to the health center just for imaging and the report check or review. The touring doctor bring this to them. IRC also support TruckBack's mobile exam room, bring X-ray examination from health center into the community. So we bring the service into the community. The service of IRC actually relieve the uneven distribution problem of the medical resource. We don't need to allocate everything to the remote sites, but digital connected method, the remote area could share the medical resource with the metro citizen in the same standard and quality. This connected method bring more flexibility. What kind of flexibility? The flexibility of examination, the flexibility of the medical human resource and their professionals. Thank you.
Thanks a lot, Andrew. So again, now I'm going to connect two of my panelists. First one is Delhi. Delhi, in terms of digital health platforms and the kind of work you do, especially in primary care, you need to address the needs of the bottom of the pyramid and in the areas, remote areas where you actually don't have doctors. So what kind of scope do you see in PPPs first? Second question, again, Piyush, I'm connecting you here. That's simply because we see a lot of studies where people are pushed into the below the poverty line because of medical treatment cost. And that brings in the demand for microfinancing, providing them different payment options and other things. So how do you address that? So I'll start off with you first, Delhi, and then Piyush to take over.
Thanks, Doc. Thanks, Doc. Hope I'm audible. See, first we need to understand that the government spends approximately 1% of the GDP on healthcare, with 60% of the healthcare expenditure coming out of the pockets of the consumer. Second is accessibility is a very big challenge in rural areas. Third, there is a massive shortage of doctors, nurses, paramedics. Even if you look at the WHO recommendation, we are far lesser than the doctor-patient ratio in India. Having said that, the private-public partnership PPP model can be an answer to India's healthcare challenge. So when you talk about how best it can help, you can look at various other areas like energy, infrastructure, urban development, and many, many more where this model has worked wonderfully well. When you have the PPP model, what helps is government may gets funds which are required to make healthcare available, as well as to create a sustainable long-term model. Plus, it helps boost the entire healthcare system by pooling in resources, financial as well as expertise from the private sector, and with the grants and access which the public sector has. Apart from the finance bit, a few more contribution from the private sector could be in terms of development and strengthening the entire healthcare infrastructure across the geographies and at all levels of care. Second could be management and operations of the health facilities in terms of technical expertise, economy optimization. Third could be capacity building for professionals, semi-professionals, ancillary staff which are involved in healthcare delivery. And also from the government side, there could be various aids which could interest the private sector to be more involved through offering grants for capital and for capital expenditures, offering assistance when it comes to setup of infrastructure like land acquisition, offering equity participation. Yeah, I think it can be a fabulous model and can be the biggest solution to our challenges. Thank you.
I'll take it forward from here. So, like you asked, Dr. Gandhi, they're in the remotest of the places. They might not have enough money for making the payments. The concept of one integrated payment solution and a payment system is not just about the payment methods available, like a POS machine or an online payments or a UPI, but also bringing in payment systems like microfinance models, like financing options, connecting parties who are ready to finance your healthcare onto the platform so that you can generate that finance and complete the payments through the platform itself. Now, there are scenarios, there are situations where we've seen that there are personal loans that people have taken up, and what they've done is they've not funded their entire health through that. They've just gone ahead and bought, maybe a car or a bike, and the remaining they've put into their health stuff. So what we are trying to build a model or trying to build a platform that the entire financing for your healthcare happens for that. And you're not going to probably a loan shark, wherein they're upselling, oh, you need 5 lakh for healthcare. Why not take 8 lakh? 3 lakh, you can buy a bike for yourself, or you can buy, some of your home stuff or home renovation. What you're doing is you require only 5 lakhs. So the platform pushes you and helps you gaining that 5 lakh not at 24% interest rate annually, but maybe like a 6% or a 7% or a 10.25% interest rate, trying to build that model. Now, this is not only solution, getting payments from somewhere. There are insurance policies, there are health insurance systems that are available by the government, like a Bhamasha Yojana that he talked about, Ayushman Bharat Yojana that the government of India has. Why can't we bring these systems onto a payment platform? Why can't we have the communication happening from this integrated payment system that, okay, the health insurance will fund 5 lakh of your fees, but your total fees is 10 lakh. 5 lakh, you make the payment, and this 5 lakh can go directly to that system and bring that money for you. So in this way, hospitals get to know that this is being financed by the insurance company, or this money is going to come from the insurance company, and this is the out-of-pocket payment. And bringing that entire ecosystem together, that should be our bigger focus. So financing options, definitely. There are a lot of players available who can help you do that. And there are a lot of fintech companies who've come up who are ready to give you finance in as less as 1 minute. They're ready to give you that. So you get pre-approved loans, even your banks if you go in. But there are people who don't have banking available with them. So how do you finance them? So there are, again, fintech companies who've come up who, without those information, but taking some brief information about your credit history, about your credit score, about payments that you've made here and there, based on that, they're able to loan you certain funds. But these are risk funds which can be taken up. And that is where a platform comes in, wherein you have all these payment systems that are there on this individual platform, which platform can be made not just available to the hospitals, but can be made available to the end user. And when they're taking any money for their healthcare services, they're spending only for their healthcare services. And the funds are going directly passed through, and you have track of each and every penny that is coming into the account, each and every penny that is being sold. So not just payment systems, payment modes, but how can we bring in these insurance systems and insurance platforms as well as part of the solution, which can ease this entire track? That would be my bit.
Thanks so much, Piyush. Pretty interesting. Now I'll go to Akhil first, and then followed by Dilesh. So Akhil, like you spoke about, you wanted data regarding tuberculosis, hypertension, diabetes from multiple regions. That requires interoperability. That requires multiple systems to talk to each other, and that consolidated data across, a particular region or whatever you want to analyze, an age group maybe. Now, on one hand, the way Piyush has described, all history can be made available. You can have interconnected systems and interoperability. And then I'm going to go to Dilesh about this, that since we have so much data and all of us have got HDFC Bank calls for personal loans, so how do we ensure privacy and confidentiality and not bugging the customer too much?
Amazing. Privacy matters. So agree, we have that. That's what the point is, like, knowing is knowing and doing is doing. We know we have data. We know we have solutions. We know there are the ways to, handle that kind of a challenges or problems. Like Dr. Rao precisely told that, future telemedicine, I'm totally agree with you. Like, that's the future. But how many years we are talking about this thing, and how many years we are gathering this data from various insurance and TPSs from so many years, and they are collecting our data, all medical records and everything from so many years. So we have that data. We have that kind of a softwares who can analyze that kind of a data and give the precise, analytics to, like, marketer like us, that चलो भाई इसको diabetes है, इसको ये बेचो. Like, like you Google something on a phone, and immediately on Instagram and a Facebook and YouTube, you'll start seeing those kind of advertisements. We are the culprits. Like, we know how to, manipulate those data. If you are into the Google, how to read and how to listen your data, privacy. iPhone says, like, privacy, but we know how to manipulate those things, and it's there. People, like genius people, is like so again, interoperability. We can do it, very much doable, provided we connect the dots, we connect the basics, and I was like, in morning we were discussing like why Amazon is everywhere in India, and why not telemedicines or like platform like finance and various platforms are there in rural areas. We are seeing in two countries. There is one India and there is one Bharat. Everybody is talking about India, 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 India. India is this. Bharat. Everybody is talking about Bharat. It's a future. It's a economy. बहुत business है वहाँ पर. Accessibility is the issue. Reach is the issue. So we know the market, but unfortunately we don't have awareness. I'm very sorry to say, like maybe because a marketing budget for this kind of a tech, this kind of applications, this kind of solutions are not used or not put precisely, because we need to market those things. And I must say, how many of you have seen, there is one national advertisement of a YouTube 3-4 days back on a Times of India front page? Have you, because it's like, if you go online, you'll find YouTube had done that kind of, the full page advertisement on the front page of a Times of India, saying that, 63% of our users search for the skill enhancement on a YouTube. Do you think YouTube required that kind of a traditional media, the print media? Why they are doing this kind of awareness into the market? Amazon, whenever they come up with that, they come up with that grand sale, they used to take that front page advertisement. They create the awareness. In pandemic, when we were like locked and we were using the telemedicines and WhatsApp call and Zoom call and Google Meet, that time Facebook, Google and WhatsApp were doing TVC. Television पे advertisements आती थी, WhatsApp की. Emotional advertisement, that nurse is at somewhere and her patient and nanny at somewhere else, and there was like communications, and there was like a video calling, and she's taking care of that patient through WhatsApp. So why WhatsApp requires that when entire world is using that platform? They are the big giants. They know everything. Still they are using the traditional media to create the awareness of their platforms. And we talking about the digital healthcare, I think what we are missing and what the solution for interoperability and kind of is the awareness. Inside out, if we'll create that kind of awareness inside first to our care providers, that this is what the solution we have it. Like from morning I was listening so many solutions, which actually I was not aware about it. Okay, Baba, we have this kind of a genius around. But being into the healthcare professions and healthcare from last 20 years, there are new innovations. Thanks to, again, Mr. Sir, VOH platform that, you all are, bringing all minds together to create the same mindset. So I think interoperability is very much possible if we'll create the awareness, taking care of the privacy and confidentiality of the data. Thank you.
So thank you. Dr. Nitiraj, I'll answer the question in two parts. The first is data generation, how that happens. So there was this interesting framework from NEHC, which is a public-private body in US. They came up with this framework for patient engagement, which had got 5 points there. So inform me, engage me, empower me, partner with me, and support me. So these are the 5 tenets where the patient needs help from us, right? Each of these points are places of potential IT interventions, tool interventions, which generate data, right? So that is an opportunity for IT product companies like ours in the information or engagement or empowering the patients. Again, NDHM is a direction in that place, right? Now, having generated this data, how can we ensure security? So what we commonly tell, or what I commonly tell the clients is we have a TTC framework for data. What is this TTC? First T stands for transparency. All our agreements which we have with our partner hospitals, we make sure that there is a clause which mentions about this, that your data is not going to be used for so-and-so purposes. That's one point. Next is technology. How can we use technology and give the confidence to the clients that your data is secure? So what all things we can do? We have encryptions, we have secure, say token authentications. We have AWS servers, which are pretty secure with all the compliances. And C stands for certifications, which I mentioned, like ISO 27001, HIPAA compliance certification. Disha is another one which is coming in that direction. So once you have complied to this TTC and you tell your client that all these three things are taken care of and prove that to the client, I don't think there is a room for any doubt further once you have these in place. And that's where we always strive to gain the confidence of our clients by following this TTC framework. Thank you.
Thanks so much, Dilesh. I would have added another T of trust. I think. So, no. Okay, now I'll come to the doctor. I think he's heard all the conversations, Dr. Nageshwar, and how does that make you feel as a doctor? Because you've been from, you would have seen the transition where people had this asymmetry of information. The patient doesn't know more about his condition and is relying completely on the doctor. Then the generation started where they Googled everything and they came to the doctor. Now you have a generation where you have everything on your fingertips on the mobile phone and you are choosing the doctor actually. You're not telling the doctor that these could be my symptoms. You're actually choosing the doctor. And that's what connected healthcare is also. Probably it's the bane of connected healthcare or probably a boon, depending on how the patient lands up. It could be a good condition, bad condition. So as a doctor, what's your prescription for this?
Right. I think I have a bad news. Bad news is our communicable, non-communicable diseases proportion in the total health disease profile was 30% way back in 1990. The 30% has grew today to 55.5% as per 2016 numbers. This is expected to grow to 83% in another 20 years. It means the disease profile of the global disease profile is going to change from the communicable to non-communicable. Non-communicable is going to take the major share, which is around 80%, is not a joke. In fact, it's a bad thing that to be discussed or announced. Now, I want to see smile on the promoters who are here for the telemedicine or home care guys. So the good news is, if you keep this fact of non-communicable diseases growing in a big way, so these platforms are going to be the future weapons to handle this burden on the society. I'm sure our population, we can't keep producing n number of doctors, n number of nurses, n number of paramedics. That's going to be, somewhere stop. Now, so if you look at those numbers, this is going to be a very encouraging way forward for telemedicine as well as home care. The overall business profile of telemedicine globally today, in 2018, it was 38.3 billion. This 38.3 billion is going to go to 139 billion by 2025. So that's at a CAGR of 19%. Interestingly, India's CAGR for telemedicine is going to be 22.4% and China is going to be 23%. I think these numbers are quite good enough for the promoters to have a broad smile on their face to go pump in more money. And then undoubtedly, I think eventually all the stakeholders in this game are going to be online. And we will have no options left except to go to these virtual platforms or telemedicine or home care. And I'm pretty sure, I think, as the time keeps going on, we'll all be on one line and then all put together. The telemedicine and the home care is definitely going to be there at the end point. Thanks, everyone.
Thank you so much, sir. So last word, Andru. We have Andru on the line.
Yes, I'm still online. Can you guys hear me?
Can the technical team please check if we have our guest from Taiwan joined us virtually?
Yes. I'm Andrew. I'm still online.
We can proceed with the next round of questions if they are.
I think
Okay.
we're done with the
Okay.
questions. So
Okay.
thanks so much to all the panelists and the audience for being patient post lunch. I hope this was good food for thought after a really appetizing meal. Thank you so much. Okay, Andrew's back. Andrew, just
Yes.
wrapping up.
Yeah, I'm still with you.
Yeah. Andrew, can you hear us?
Yes, I can.
Yeah, so Andrew, just a bit about your experience with the mobile clinics and IRC. If you could just wrap it up with that, that would be great.
Okay. The latest portable solutions we use in IRC, there are three elements in this scenario. The first one goes to the mobile exam devices. When modality goes mobile, technician could perform exam from the department, even outside the facility. And the second one goes to the portable PACS system to acquire the image that modality produce. And the third one is artificial intelligence support and remote professional support. Firstly, the mobile exam device. Technician bring the mobile examination equipment to the community or the patient's house, even the bedside. Such like the modality, the sonography, the global brain GE has the V-scan sonography. It's a handheld device. It's battery-based, and you can bring it to the bedside with the technician. And goes to the X-ray. The Fujifilm, a Japanese brand, they produced X-Air, also a handheld X-ray equipment. Then it can perform the bedside examination for the patient. So we bring, in the last stage, we bring the service with truck to the community. And this time we bring the service into the household. And the second one, the micro PACS system. EBM developed a Apple application, iOS application, we called it the UDE. It's an FDA-approved application. Make a normal Apple iPad into a server, storage, and the medical display. Also, it's a portal of the AI and telemedicine, which means you can access the AI implementation services via UDE app. With the embedded, we use the core ML technical to put the AI model on the iPad or the cloud-based AI model for primary classification. Maybe you will say the technician take this device and took the examination for the patient, but without the doctor's diagnosis. So don't worry about that. The UDE can announce or image telemedicine. How to do that? Use the iPad to acquire the image from the medical records, send the image to the remote site for consultation, even launch a telemedicine console immediately. And it goes to the third element, remote support and the tutoring. Doctor and the technician on duty in hospital could provide diagnosis or suggestion or even tutor the performer to better practice of the examination. Also, we can do that is to train the AI model. The most frequently diagnoses, such like TB or pneumothorax or pneumonia, such kind of disease could be trained as an AI model to help the first-line technician for classifying. This AI method plays the role of remote support that's always on duty. Okay, thank you.
Thanks so much, Andrew, and thanks everyone again for this wonderful panel. Thank you, Voice of Healthcare.
Thank you, Dr. Gandhi, for so skillfully leading this session for us. I thank all our guest speakers for staying with us. I apologize for the inconvenience with the technology. We sincerely hope with so much deliberations on technology with healthcare, we are also able to advance pure technology. Thank you so much. You may please take your seats. Before that, I request Mrs. Sugandha Nayak to please felicitate Mr. Dsouza. I request Dr. Biren Chauhan to please felicitate Dr. Nageshwar Rao. I request Dr. Rajesh Shah to please felicitate Mr. Piyush Bhan. I request Mr. Ravinder Singh to please felicitate Mr. Dilesh Dattani. I request Mr. Prabdeep Singh to please felicitate Mr. Akhil Dave. I request Mrs. Feni Ganatra to please felicitate Dr. Nitiraj Gandhi. Thank you so much, everybody. With that, we round up the third round of panel discussion.